Good morning, everyone, dear colleagues, professors, and those of you watching online. Thank you for taking the time out of your busy schedule. It is a tremendous honor to be here in Toronto as a representative of South Korea for the MegaMind 2026. My name is Jung Kim, and today I'll be presenting on the topic comprehensive reconstruction of the occlusal scheme from single aesthetics to full mouth rehabilitation. To briefly introduce myself, I come from Seoul, the capital city of South Korea. Seoul is a truly beautiful city where the tradition and modernity coexist in perfect harmony, especially the proud hometown of Megagen. Korean traditional design and nature fit together perfectly. Of course, Korea is also globally recognized for K-culture, from the energy of K-pop demon hunters to superstars like BTS and Blackpink. I do recommend you to visit our country at least once in your lifetime. I was born and raised in Korea, where I followed my passion to become a dentist. Today, I'm incredibly happy to challenge myself once again here at the MegaMind. And I was also one of the top 21 finalists at the MegaMind 2024. The experience allowed me to evolve and broaden my perspective in dentistry. I'm a periodontist, Dr. Jung Kim. So back to my topic. My topic today is comprehensive reconstruction of the occlusal scheme. When we treat a patient, we often focus intensely on the teeth. However, as clinicians, I believe that true restoration begins with understanding the patient's entire face. The harmony between the interpupillary line, the facial midline, and the occlusal plane is the foundation of every successful treatment. Today, I'd like to share 3 cases that demonstrate the face-driven approach across the different levels of complexity. The first case is about aesthetic rescue. One hot summer day, a young foreign female patient visited my clinic with malpositioned implant at the site of maxillary left central incisor. Due to the improper 3D positioning of the fixture, she was suffering from a severely elongated clinical crown. As you can see, the complex problems of this case included the position and axis of the fixture, soft tissue atrophy, and an excessively wide horizontal space. In the extraoral photo, we can easily detect the facial asymmetry. The interpupillary line, the commisural line were not parallel, and left mandibular ramus is shorter than the right side. To resolve this nightmare, a simple prosthetic change was not enough. So I decided to perform explantation on extensive GBR and soft tissue augmentation. Following the explantation, first GBR was performed using xenograft and membrane. This initial GBR is similar to the protocols of alveolar ridge preservation. Compared to the baseline, a slight soft tissue gain was observed. However, after 3 months, a horizontal deficiency still existed. Therefore, to further increase hard and soft tissue volume, a second GBR and soft tissue augmentation were initiated. On the buccal flap, a reverse partial incision was used to extend the length of buccal flap. Following the placement of Megagen blue diamond fixture, second GBR was performed using xenograft and resorbable membrane. Concurrently, a VIP CT flap was mobilized from the palatal site above the healing abutment to maximize soft tissue volume. To summarize, first and second GBR rebuilt the collapsed hard tissue foundation, and also the extended flap design on the labial side and VIP CT flap techniques on the palatal side successfully increased the soft tissue volume vertically and horizontally. Following the surgery, the cantilever provisional crowns were delivered. Through this sequential CBC scan at baseline, first GBR and second GBR, we can clearly detect the step-by-step increase in hard tissue as well as fixture axis transformation. The schematic drawings of these protocols illustrate the precise hard and soft tissue augmentation process. To determine the ideal anterior occlusal plane, the facial analysis was performed. Due to the facial asymmetry, we decided to orient the anterior occlusal plane at the bisecting angle between these two reference lines. We use these lines as an anterior occlusal plane. After 2 months, the gingiva healed well, but a minor deficiency remained at the distal part of the central incisor. Therefore, during the second surgery, I rotated the crestal gingival tissue to the distal part. This is the clinical photo after second surgery compared to the baseline, and healed soft tissue after 1 month. We took the final impression in this state, and this is the final restoration. A remarkable aesthetic improvement was observed compared to the baseline. Here is the final smile and full facial photography. By aligning prosthetic design with her unique facial landmarks, we restored her natural aesthetics and, most importantly, her confidence. Moving on to the second case, we'll discuss the functional and aesthetic rehabilitation of a middle-aged female patient who had been struggling with her old denture for a long time. For the facial analysis, as you can see, her existing denture had two major issues. First, the dental midline, the maxillary dental midline, was deviated from the facial midline, and the anterior maxillary plane was canted, inducing the upper denture shifting to the right side. That's why her right teeth were exposed even with subtle smile. Second, there was a complete lack of retention and stability. As a result, a new complete denture on maxilla and mandibular implant, fixed implant prostheses were planned, also considering the patient's financial constraints. Her old upper denture was severely canted to the right side, so we needed to rotate the new denture design clockwise. Fortunately, the teeth positions of our lower denture were within the normal range. We used this denture as a reference like a surgical guide. The placement of 6 implants was planned on the mandible. So we prepared 6 holes at the planned position on the denture. Before the surgery, these holes were filled with temporary bond, and we confirmed the planned positions through the panoramic radiograph. During the surgery, we verified positions once again using the guide pins, and all implants, blue diamond manufactured by Megagen, were successfully placed inside the bone. To allow the sink down process and adaptation period, provisional crowns were used for 2 months. Afterward, we designed final zirconia crowns in 3 separate segments. Finally, the 3-piece zirconia prosthesis was delivered. The occlusal view and CBCT scan showed that the implants placed in the accurate planned position. After finishing the mandible, we began the process of making the upper denture. The vertical dimension was determined using wax rim, and following the 3D setting, a temporary wax denture was fabricated. We took the CBCT scan while the patient was wearing this temporary wax denture. By using AI-based software, we can get many kinds of landmarks determining several planes. We confirmed that the occlusal plane of the temporary wax denture was parallel to the interorbital line and campus line. In addition, the angle between the FH plane and occlusal plane was about 10 degrees. According to the literature, the appropriate angle should be around 9 to 10 degrees. If the angle was not within the ideal range, we'd have modified the VD or teeth arrangement. Since our set occlusal plane was within the normal range, we proceeded with the CAD software to arrange the denture teeth. After milling the denture teeth and base, they were bonded and further refined. Finally, the maxillary complete denture was made and delivered. As you can see this video, the retention issues she had with old denture was completely resolved. Comparing before and after, the dental midline now perfectly matches the facial midline, and successfully reconstruct the overall occlusal scheme. Now let's move on to our final case. This involves 52-year-old male patient requiring full mouth rehabilitation with occlusal vertical dimension increase. Starting with the facial analysis, as you can see, the maxillary and mandibular dental midline were not coincident and deviated from the facial midline, and the severe attrition on the anterior teeth was observed. Looking at the intraoral view, there is significant incisor chipping. Furthermore, the occlusal plane shows reverse curve. The primary reason for the extensive anterior chipping was the insufficient posterior support. This led to excessive occlusal forces being concentrated on the anterior segment. Our model analysis from lateral and frontal view, we confirmed that reverse curve and multiple incisor chipping was direct result of an under-restored posterior occlusion. So our goal was to establish a new occlusal plane by increasing the OVD. As a result, with these detailed techniques, full mouth rehabilitation using crowns, overlays, and implants with OVD increase was planned. First, we performed the immediate implant placement on the left side, and based on the diagnostic wax-up, we established the new occlusal plane and prepared provisional crowns. We followed the step-by-step approach for the OVD increase. First, we placed mandibular provisional crowns, increasing OVD by 2 mm at the incisal level. Then we allowed 6 weeks for the neuromuscular adaptation. Afterward, we placed maxillary provisional crowns, adding another 1.5 mm increase, followed by 6-week adaptation period. Through these sequential adjustments, we gradually corrected the dental midline and refined the occlusal plane. Compared to the baseline, the final provisional state shows the improvement occlusal plane and midline. The CT analysis showed that the newly established occlusal plane of the provisional state formed 10 degrees relative to the FH plane, which is within the ideal range. A 2012 systematic review reported that a 5 mm maximum increase in OVD can be justified to provide adequate occlusal space for the restorative material and to improve anterior teeth aesthetics. In this case, the total increase of 3.5 mm was well tolerated by the patient. Based on these approved provisionals, we can proceed to the definitive restoration phase. First, we fabricated and delivered posterior zirconia crowns, establishing a posterior stable support. Afterward, the definitive anterior crowns was designed and delivered. This is the final restoration. Compared to the baseline, the correction of dental midline, the elimination of reverse curve, and the refinement of the overall occlusal plane, all of which were calculated in the provisional state, were successfully transferred to the final restoration. The panoramic comparison between before and after, 1-year follow-up clinical photo. Initially, he had old-looking appearance characterized by severe tooth attrition and the excessive exposure of mandibular teeth when smiling, but after treatment, his maxillary teeth are beautifully and naturally displayed when smiling, and also he even decided to get a custom hairpiece, so he became more vibrant and younger. We didn't just reconstruct his occlusion, but we restored his youth and quality of life. This is the end of my presentation, and I'd like to express my gratitude to our 3 patients who trusted me and walked with me through this long clinical journey. All of them are smiling like me, and I sincerely appreciate my partner Jung and Master Dental Technician Kyung-Mi Lee. Thank you very much. Thank you for your attention. Thank you.